Okay, let's look at the actual protocol. So here's our traumatic cardiac arrest protocol. It starts with our statement at the top. I do want to point out something with our statement here. The trauma cardiac arrest protocol is talking about the management of a patient in cardiac arrest due to a blunt or penetrating injury. That is specifically said in there. We really want to think of this as those trauma patients that have arrested from this blunt or penetrating injury, not a asphyxiation or hanging or drowning, where those would be more of a hypoxic cause, right? If we think about the actual cause, here we're thinking about blunt or penetrating, blood loss, all those pieces of the March algorithm that we're going to be targeting really focus on that blunt and penetrating trauma part. The next part I want to point out is the scope. This is BLS, ALS, and critical care. There are parts of this that span all of those scopes, and it's really important to not leave out the BLS providers in this. I think that they handle a lot of what you can do within that March assessment and really can make an impact on our trauma arrest patients. So let's go down to the next part. So criteria for intervention. And again, we've stated it one more time. This is a blunt or penetrating injury that's causing our arrest. We really want to focus on that and think of, again, those hanging or drowning patients as more of a hypoxic or respiratory cause instead of a blood loss cause or things like that. And of course, our standard exclusion criteria that we would have on any cardiac arrest, whether it be medical or trauma, are going to be listed in here as well. Okay, now we're down into the meat and potatoes of it, clinical treatment guidelines. At the very top, you're going to see this refer to algorithm for quick reference, and you're going to see that's highlighted, that word algorithm. It does have that hyperlink built to go straight to that algorithm. It's a really nice flow chart, has a decision tree to kind of help you visualize and walk through the decision-making process on a trauma arrest call. We'll bring that up here in just a second and kind of walk through that as well. Now the next step is assessing for a medical cause of arrest. Now if you pull up on an MVC, it's a lower speed, there's not a huge mechanism, doesn't look to be a lot of massive injury to the patient, but they are in cardiac arrest, well then maybe this was a medical arrest that then caused the car crash, right? So some of this could be, chicken or the egg, right? What caused the actual arrest? Was it medical or trauma? So just kind of keep those things in mind. And don't forget about your basics like hypoglycemia, overdose, or just plain medical arrest doing it. Now, if this is more of a hypovolemia issue, we want to continue down that March algorithm and remember controlling hemorrhages right at the top. So controlling that hemorrhage, treating for shock protocols, and if you have the availability, blood products early and often is really great. We do want to address the airway, but again, we don't want the airway to take away from stopping those life-saving interventions. One of those being our chest venting, right? Now we do have tamponade in here, and recognizing those pieces, we don't have any way to treat that, but we do want to keep that in mind as we work through our H's and T's, that being one of them. Here's a look at the trauma arrest algorithm. So we're going to kind of break this down, and we'll use this throughout our scenarios. From the top, it does tell you blunt or penetrating trauma. We want to really emphasize that. If this is a hanging patient, if this is a drowning patient, those are more of a respiratory hypoxic cause of arrest, and we really want to focus on reversing that piece. But here we're talking about blunt penetrating trauma. Now the first step, do they meet that obvious death criteria? Yes or no, and then you continue down through. And then we want to double check, is this a medical arrest? Yes or no, and then we'll continue on down. So we're going to go ahead and say this is a trauma arrest, and as we filter down, we're going to go ahead and hit the simultaneously addressing those reversible causes, those life-threatening injuries. And we want to try to get them, if we have the hands, if we have the resources, all at once. We're going to target all four of these pieces: hemorrhage, oxygenation, tension, pneumo, and then again, considering that tamponade and keeping that in our mind as we go through this. Once we target all of those, we're going to continue on. Did that work, right? Did we get ROSC? If yes, great. If no, we'll continue our resuscitation, and if that goes greater than 20 minutes, then we can go ahead and readdress things as a team and consider to terminate efforts. So let's see how this works in the real world. In our first scenario, Magic Valley Paramedics is dispatched to a motor vehicle collision in town. Upon arrival, you find that your patient's been ejected from a vehicle and is found pulseless. They present with no obvious external hemorrhage, but have crepitus across the chest wall, suggesting significant blunt force thoracic trauma. Now let's walk through this using our trauma arrest algorithm. Looking at the algorithm, we know they're a trauma patient in cardiac arrest. We know it's blunt trauma. It doesn't meet obvious death criteria. Now we don't know what caused the accident, but we can go ahead and assume the mechanism was what caused our current state. Now, had this been a minor MVC and they were just kind of found slumped over the wheel or in their chair, then maybe we consider those medical causes. Now, the next phase is where that March algorithm comes in. And ideally, we're achieving this simultaneously. So let's break it down. Even though there's no visible bleeding, we still need to consider internal hemorrhage, especially with a mechanism like ejection. One of the first things that comes to mind for me is resource allocation. Is your team EMT paramedic or dual medic? Did multiple units get dispatched, or is there a fire or QRU response on scene? All these factors can dictate the focus of the advanced providers. But it's important to call out that the majority of the March assessment can be done by a BLS provider. The first step is applying a pelvic binder, assuming that with the mechanism of getting ejected from a vehicle, there's a high potential for pelvic fracture and internal bleeding. No tourniquets or wound packing are needed here, but the binder is a critical step in controlling hidden hemorrhage. Now, the patient is in arrest, so airway management is needed. BLS providers can initiate BVM ventilations with an airway adjunct. ILS providers could go ahead and escalate that up to a supraglottic airway, and that would be a little bit more secure and compliant as far as ventilations go. Now, this should be done quickly and efficiently. Remember, airways shouldn't delay other life-saving interventions. Now, a key concern in this case is the chest wall crepitus. It really raises suspicion for a potential tension pneumothorax or flail chest. ALS providers would perform bilateral needle thoracentesis due to the mechanism and the arrest status. Now, your ILS providers could establish IV or IO access to begin resuscitation. For the ALS providers, that means administering TXA early to support clotting and reduce internal bleeding. While head injury is possible, our focus here is more on preventing hypothermia, which can worsen coagulopathy and acidosis. Your BLS providers could wrap the patient in blankets to preserve body heat, a simple but vital step in trauma care. Now, we want to limit our scene times and establish rapid transport to a trauma facility. I do want to emphasize that airway and transport shouldn't delay life-saving interventions. You can imagine that with the proper resources and training, all these life-saving interventions could be done rapidly and with minimal advanced providers on scene. Now let's look at how it changes with the addition of a critical care team. This next scenario is a single motorcycle crash into a guardrail. Due to the location and severity, both ASL2 and MVP were dispatched to the scene. Now, they arrive minutes apart from each other and they begin their targeted approach to resuscitating this trauma patient. The patient's found pulseless. They have massive hemorrhaging from their left lower extremity, including an open tib-fib fracture. There's abrasions all over the body and an angulated right radius. Now, this sounds like a lot to handle, but using our trauma protocol and following the March algorithm, we can resuscitate this patient quickly and efficiently. Starting with massive hemorrhage, tourniquet application to the left lower extremity should take priority. Pelvic binder should follow, as we assume pelvic injury in any patient in trauma arrest with a mechanism suggestive of any blunt force trauma to the pelvis. These are treatments any provider can do. Even a trained law enforcement officer could assist with tourniquet placement if resources were limited. Again, we start at the BLS level and increase accordingly to what resources we have available. For this scenario, we have an advanced provider available to secure an airway. I would still recommend the quickest device to secure the airway that doesn't distract from other life-threatening injuries. Here I think other factors come into play. Does the rest of the team need help setting up for blood product? Are all the rest of the life-threatening injuries treated and advanced airway placement is really what's holding up transport? Maybe a supraglottic airway is your best choice for this patient. With critical care on scene, we do have the option for tube thoracostomy. While this is a more effective way of ending the chest, it does take longer to perform. If there's any delay, consider needle decompression first then move to a more permanent and effective procedure when time allows. Now the big change here is the addition of blood. In this scenario, we have both paramedics and critical care providers. Good teamwork and communication is critical as most of the treatments cross everyone's scope of practice. Critical care should focus on blood administration and advanced chest venting, as the ALS paramedics can handle the rest. Of course, don't forget about heat loss prevention. It's simple but often overlooked. If you do achieve ROSC, maintaining proper homeostasis is critical to preserving clotting factors. While we always want to limit our scene times and establish rapid transport for all trauma patients, I do want to emphasize that airway and transport shouldn't delay life-saving interventions. You can imagine that with the proper resources, training, and communication, all these life-saving interventions could be done rapidly and with minimal advanced providers on scene. Now I want to call out some of the special considerations found in this protocol. During a medical arrest, chest compressions take priority. Circulating the remaining oxygenated blood while the heart is unable to is what saved lives, and we see that in the difference in outcomes with and without bystander CPR. Now for trauma arrest, chest compressions are not a priority. They delay the treatment of life-saving interventions, and as you can imagine, in the presence of a massive hemorrhaging, pumping the heart before stopping the bleeding, it's only going to make them exsanguinate faster. For pregnant patients, we don't have a specific week designation, as this can be challenging information to obtain during a scene call, especially one involving traumatic arrest. Here we check for fundal height at the level of the umbilicus to determine if uterine displacement is needed during resuscitation. We also understand that some scene calls can be challenging for a multitude of reasons. That's why we want to give you, the providers, both the flexibility and the guidance to determine whether a patient should be worked on scene or if it's more appropriate to initiate a rapid transport. Pediatric arrests can certainly fall into this category. I can think back to several calls where working the patient on scene was either unsafe or not conducive to effective resuscitation. You're the ones on scene. We trust your judgment. Just remember to address those life-threatening injuries as quickly as possible, even when the rapid transport is the best course of action. As we wrap up this training, let's take a moment to reflect on what we've covered. We started by acknowledging that traumatic cardiac arrest has long been viewed as futile, but that mindset is changing. With emerging data, evolving protocols, and a deeper understanding of trauma physiology, we now know that targeted, timely interventions can save lives. The MARCH algorithm gives us a structured, evidence-based approach to trauma care. We stop massive hemorrhage first because, well, bleeding kills fast. We secure the airway using the simplest method that works. We address respirations, especially attention pneumothorax, with a low threshold for decompression. We restore circulation, prioritizing early access and, when available, early whole blood. We manage hypothermia, recognizing its role in the trauma triad of death and doing everything we can to prevent it. Every level provider, BLS, ILS, ALS, critical care, we all have a role to play. And when we work together, guided by a shared protocol, we give our patients the best possible chance for survival. This isn't just about following steps, it's about changing the narrative from, there's really nothing we can do, to we know what to do and we're ready for it. Thank you for your commitment to learning. Thank you for your commitment to your patients, and thank you for pushing the boundaries of what's possible in trauma care.